All right, let's get right into it. The best way to think about your heart is like a house. It's got this incredibly complex electrical wiring, right? And for everything to work, from the lights to the TV, power has to get to every single room in a perfect, coordinated sequence. Well, that's exactly what's happening in your heart, making sure it beats rhythmically and pumps blood where it needs to go.
But what happens when that wiring gets messed up? When it starts to short circuit. In the heart, we call these glitches arrhythmias. And these electrical problems can be anything from a harmless little flicker, that feeling of a skipped beat, all the way to a life-threatening power outage, like sudden cardiac arrest.
And that is where cardiac electrophysiology, or EP as we call it, comes in. You can think of an electrophysiologist as a master electrician for the heart. And believe me, the field has come a long, long way. We've gone from just looking at the heart's electricity from the outside with an ECG to actually going inside the heart with these tiny wires or catheters to map its intricate circuits in real time. It's all about finding that fault and, you guessed it, fixing it.
Now, to really understand how the entire system can fail, we have to start small. We have to zoom way, way in, from the whole heart down to the spark in a single cardiac cell. This is really the fundamental building block of the whole electrical system.
And this brings us to the most basic command in the heart: fire. The action potential is that fundamental electrical signature of a heart cell. It's basically the on switch that tells the cell to contract. It's this super fast, regenerating change in voltage across the cell membrane that lets that electrical wave travel from one cell to the next.
But this isn't just a simple on-off switch. No, it's this beautifully orchestrated dance of ions. It all starts with phase 0, when a stimulus opens these fast sodium channels, and bam! Sodium ions rush in, causing that sharp spike in voltage. Then comes phase 1, a quick little dip. Phase 2, the plateau, is absolutely crucial. This is where calcium channels open up, letting calcium in, which not only keeps the cell on, but also triggers the actual muscle contraction. Next, in phase 3, potassium channels open, potassium rushes out, and the cell's voltage comes back down. And finally, you have phase 4, the resting state, where the cell just waits, ready for the next beat.
Okay, so this is super important. Not all heart cells are the same. You've basically got two types. On one hand, you have the pacemaker cells. These are the leaders. You find them in the SA and AV nodes, and they're special because they can generate their own electricity spontaneously. They set the rhythm. On the other hand, you have the myocytes. These are the worker bees, the muscle cells that make up the rest of the heart. They're the followers. They just hang out and wait for that electrical signal from the pacemakers before they contract and do the heavy lifting of pumping blood.
So, now that we've got the basics down, we can talk about how this elegant system breaks. It really boils down to three main culprits, three fundamental ways the circuits can fail, that cause pretty much all arrhythmias.
First up is abnormal automaticity. This is a problem with making the impulse in the first place. So remember those worker cells, the myocytes, that are supposed to wait for a signal? Well, under stress, say from a lack of oxygen during a heart attack, or if your electrolytes like potassium are out of whack, they can start firing on their own. It's like one musician in the orchestra just suddenly decides to go rogue and play their own solo, completely messing up the rhythm.
Our second culprit is triggered activity. The best way to think about this is like electrical aftershocks that get triggered by the normal heartbeat. This is often caused by too much calcium building up inside the cell. And for your exams, this is incredibly high yield. You get early after depolarizations, or EADs, which are the cause of that dangerous rhythm torsades de points you see in long QT syndrome. And then you have delayed after depolarizations, or DADs, which are classic for things like digoxin toxicity.
And last but not least, we have the most common mechanism of them all, reentry. This is a problem with how the impulse travels, or conducts. For reentry to happen, you need a few things to go wrong. Imagine the electrical impulse comes to a fork in the road. One path is temporarily blocked. So the impulse has to go down the other, slower path. By the time it gets to the end of that slow path, the first path is recovered, and the impulse can actually travel backwards up that first path, creating a continuous self-sustaining loop. It's a perfect short circuit.
And I can't stress this enough. Understanding reentry is absolutely key in the clinic. This isn't just theory. It's the engine driving so many common arrhythmias, from things like atrial flutter to the dangerous ventricular tachycardias that happen in scarred heart tissue after a heart attack. And because it's a physical circuit, it's a perfect target for us to go in and fix.
So how does that cardiac electrician find the exact spot where that short circuit is happening? Well, for that, we step inside the EP lab. This is where we use our ultimate diagnostic tool, the electrophysiology study, or EPS.
An EPS is a really logical procedure. First, we place these thin, flexible wires called catheters into key locations inside the heart. Next, we use those catheters to record electrical signals directly from the heart tissue. This gives us this incredible high-definition view compared to a regular ECG. Third, we can actually pace the heart with tiny electrical signals to safely trigger the patient's arrhythmia right there in the lab. And finally, we use all that data to build a detailed 3D map. It's basically a GPS for the heart's electricity that pinpoints the exact origin of the problem.
But finding the problem is only half the job. The real power, the real magic of modern EP is that we can go directly from diagnosis to therapy, a lot of times in the very same procedure. The diagnostic power of an EP study is just immense. It lets us answer these really critical questions, like, is this fast heart rate coming from the top or the bottom of the heart? We can find the exact location of an extra electrical connection, like in Wolff-Parkinson-White syndrome. We can directly test how well the heart's natural pacemaker and wiring are working. And maybe most importantly, we can help figure out a patient's risk for sudden cardiac death. So once we've found that faulty tissue, we can fix it. And our main tool for that is ablation. We use the tip of a special catheter to deliver very targeted energy to that tiny, precise spot. We can either use radiofrequency energy, which heats up and creates a tiny scar, or cryoablation, which freezes the tissue. Either way, the goal is the same, to create a small lesion that can no longer conduct electricity, permanently breaking that short circuit and, in many cases, completely curing the arrhythmia.
And that opens up this huge range of therapies. We can literally cure many arrhythmias with ablation. The maps we create are also essential for guiding the perfect placement of devices like pacemakers and defibrillators. And all the data we gather during a study helps us pick the best possible antiarrhythmic drug for a specific patient, instead of just guessing.
And this really is the central theme here, the main idea. Electrophysiology is this powerful blend of elegant diagnosis, figuring out exactly what's wrong, and definitive therapy, often giving the patient a cure. It's a 1-2 punch that has totally revolutionized how we treat heart rhythm disorders.
So if you're going to take away one thing, the big, high-yield concept for your exams, it's this. If you truly understand the 3 core mechanisms, abnormal automaticity, triggered activity, and re-entry, then you understand the foundation of all arrhythmias. Figuring out which of those 3 is at play is always the first step to diagnosing and treating any rhythm problem you'll ever see.
And this all leaves us with a really fascinating question for the future. Our maps of the heart's electrical system are getting more and more detailed every single year. We're starting to understand the genetics behind these faulty circuits. So as our technology gets even more precise, you just have to wonder, what new circuits are we going to discover, and what new cures will we be able to deliver? It's an incredibly exciting time to be in this field.